everyone, I'm Lisa, for those of you who don't know me yet. I'm going to be talking about pre-hospital ultrasound. So we're going to go through some of the utilities, benefits, applications, and barriers to implementation. So I know we all live here in this awesome city of New York, where there's hospitals everywhere and transport times are really low in terms of EMS. So pre-hospital ultrasound might not be as feasible if we are living here, but there are other places with longer transport times that use both air and ground transportation. So pre-hospital ultrasound might be something that you can use in other locations. And not all of us are going to be practicing here, so who knows, this might come in handy. As ultrasound technology has become better, less expensive, and more easy to transport, pre-hospital ultrasound is an application that different EMS systems are starting to use. And it's going to be kind of important to see how we can help guide this. It's going to be part of future notifications possibly, and they might even transmit images to us to interpret. So it's important to kind of know that this is a thing that might be happening. So some considerations. Obviously, every EMS system differs in terms of pre-hospital personnel and in terms of what kind of transportation they use, whether it's ground or air transportation. Some places have physicians as part of EMS personnel, nurses, paramedics, EMT basics, even respiratory therapists in some situations. And so everybody comes in with a different knowledge base, which is kind of the biggest part of the considerations here. So paramedics, in general, when polled, were really enthusiastic about learning to use ultrasound and implementing it in part of the pre-hospital care, whereas physicians polled were a little bit more reserved about this, and they were concerned about misinterpretation, but both kind of questioned what the clinical benefit would be. Right now, there's no clear training program that has been established or been shown to be effective. And this is in part due to different knowledge bases of the different providers. So there have been studies that have been done on using online didactics, in-person lectures, sim sessions, and more hands-on scanning time. For us, as EM residents, ASAP recommends 20 to 50 scans of each type in order to be considered proficient. But how does this translate into other personnel that have less training than us? We don't exactly know yet. Some of the studies show that in terms of learning how to do a fast, the curve flattens somewhere between 30 and 100 scans, but we don't have that much great data yet. So some of the benefits, this can actually be pretty useful in terms of procedural and therapeutic interventions in the field. It can improve patient management, especially when the diagnosis is uncertain. And it can also lead to transporting to the more appropriate location or notifying the hospital in advance of what it is that is coming in. And there were some studies that show that the diagnosis and the dispo changed in about 25% of patients, and there were even some lethal complications that were avoided. And another benefit, this could be done en route to the hospital without compromising image quality, and it's relatively quick. On average, image acquisition took about 3 minutes. So some of our possible applications. So first we have airway. First attempt success at intubation in the field is somewhere between 46 and 85%, which is actually pretty poor. And it's really important to know as soon as possible whether the esophagus was intubated or if the tube's in the trachea. One study done showed that esophageal intubation occurred in 10.5% of patients, and only 30% of those intubations were detected visually or by auscultation. So I know common ways to look for ET tube placement is through direct visualization, passing the tube, seeing the tube pass through the cords, bilateral breath sounds, end tidal CO2, but there are factors, especially in the field, that can make this a little bit more difficult, such as prolonged cardiac arrest, morbid obesity, facial trauma, profuse bleeding, or vomiting. And ultrasound in some instances might be more accessible than capnography because that's expensive and disposable, whereas ultrasound is a one-time purchase. And on average, it took about 30 seconds to confirm tube placement in the field, which is really not a significant outlay of time. So what we're looking for over here is you see this double track sign where both the trachea and the esophagus, you could see through the lumens of both of them. That's bad. That's an esophageal intubation. You only really want to see the trachea. And then another way other than this to confirm ET tube placement with ultrasound is to look for bilateral lung sliding and bilateral diaphragmatic excursion. So there was this study done, which was a prospective study, a simulation study done with 50 pre-hospital providers, and they all had minimal to no ultrasound training at all, and none of them had any training in airway ultrasound. And they were initially randomized to look at where the ET2 placement was in a cadaver. Then they had a 15-minute tutorial, and then they were randomized again. And initially at baseline, the scores were 60% for overall accuracy in terms of tube placement, 55% for esophageal intubations, and 64% for tracheal intubations. And then the post-test scores, the overall accuracy increased to 82% with 96% accuracy for noticing when the esophagus was intubated. The accuracy didn't really go up much for tracheal intubations. It still stayed at about 66%, but even being able to identify an esophageal intubation is pretty significant. So breathing. Ultrasound has a really high diagnostic accuracy for pneumothorax. You could see no lung sliding, barcode sign, you could see lung points. And this is important in trauma patients to determine like, hey, does this patient need a needle decompression? There was a study done that showed about 26% of patients that got needle decompression actually didn't have a pneumothorax, and this is not a benign intervention. So being able to take a quick look at the lungs and show that there is or isn't a pneumo before you intervene can be helpful. And then in-flight ultrasound was shown to have a 91% accuracy for diagnosis, whereas in the ED it was 96%. So there isn't that much of a difference once there's training. So EMS often brings us acutely dyspneic patients, and it's important to differentiate between cardiac and respiratory causes of the dyspnea. We can look for B-lines, pleural effusions to kind of determine like, yes, EMS is going to put this patient on CPAP, but do they need nitro drip? Do they need combinebs? What's going on? So there were a couple of different proposed protocols for lung and cardiac ultrasound to determine whether the dyspnea was cardiac related or pulmonary related. One of them was doing a lung ultrasound in 8 areas of the chest, 4 anterior and 4 lateral, plus a cardiac ultrasound looking at global LV function and mitral and tricuspid regurg, plus looking at IVC collapsibility to determine whether the patient had CHF or not. Per the study, this took only about 3 minutes and was 94% sensitive and 91% specific compared to EKG, chest X-ray, and BNP to differentiate between causes of cardiac and respiratory shortness of breath. But to me, this doesn't make sense. I know how long it's taken me to learn how to do a cardiac ultrasound. I can't imagine that EMS providers who have done this for less time are able to do it in 3 minutes and that the sensitivity and specificity is as good. But who knows? The other protocol is called the Blue protocol, and this is more to diagnose different causes of respiratory failure. And it just basically looks at 4 points on either side of the chest, and they have set parameters, 10 different signs to look for pleural and parenchymal abnormalities, and they designate the different signs for different pulmonary pathologies, such as like pneumonia, pulmonary edema, pneumothorax, and this has a pretty good diagnostic accuracy and seems a little bit more reasonable to implement in the field to me. So circulation, EMS uses 4 criteria to terminate resuscitation. So no ROSC prior to transportation, no shock delivered, no bystander CPR, and an unwitnessed cardiac arrest. The cardiac standstill on pre-hospital ultrasound is a predictor of lack of ROSC. And this is something that we can possibly use to terminate resuscitative efforts. So sometimes we have PEA arrest, but there is still cardiac motion on ultrasound. And this had more positive association with ROSC compared to PEA arrest without any cardiac activity. And so to differentiate between these two when we're doing like CPR in the field can help decide like, oh, do we continue resuscitative efforts? Do we start transporting this patient to the hospital, or should we call this? And it can also be useful to detect reversible causes of cardiac arrest, such as pneumothorax, pericardial tamponade. You could see if there's right heart strain, and not necessarily act on these things in the field, but notify the hospital when you're bringing the patient in. So trauma is a big thing in the field. And obviously we want to transport these patients as rapidly as possible to the hospital, like within the golden hour. And obviously the faster we transport, the better the mortality is for these patients. Every 3-minute delay is an increase in mortality by 1%. And a pre-hospital fast can change the disposition when you're not in a place that there are level 1 traumas all over the place. patients can have a fast done. It's pretty rapid. Negative fast obviously doesn't mean that there isn't going to be free fluid in the abdomen with a high clinical suspicion. And if there's a long transport time, it should be repeated about every 15 minutes. But a positive fast is pretty predictive that it's accurate. It is pretty accurate. And it can lead to more rapid transportation of patients to the appropriate hospital, and the hospital can be notified, let's say activate MTP, prepare the ORs, you can level it in advance, which is helpful. And this can also be really good in triage for mass casualty incidents so that we know like, oh, these patients are super unstable, they need to be transported first. So there was this study done, a prospective multi-center study done in Germany using 5 air rescue centers for patients with blunt abdominal trauma. And they did a pre-hospital fast at the scene to determine if there was hemoperitoneum or not. A total of 202 patients completed this study, 28 of which had hemoperitoneum, or about 14%. There were 26 true positives and 2 false negatives, which gives us a sensitivity of 93% and a specificity of 99%. This has really good accuracy, and it changed the disposition of patients and their management in 30%. And this like really helped in terms of triage of surgical patients. So some barriers to implementation. Obviously, there's equipment that's necessary. There's costs in terms of equipment and training, challenges in terms of training that I had mentioned earlier. And of course, there needs to be further study in terms of like morbidity and mortality, clinical utility, time management, and indications for use. And right now there's no data on like potential incorrect diagnoses for pre-hospital ultrasound and what the outcomes might be in terms of patients getting misdiagnosed in that way. And we also need to consider unintended negative effects like prolongation of on-scene time, distracting from basics of resuscitation. And yeah, that's about it. So in summary, it's really most useful in trauma and PARS patients. Positive findings are pretty predictive of need of intervention, but negative findings in pre-hospital ultrasound can't really rule out a serious injury. And of course, we need further studies to assess like the clinical impact. Here are my references. Questions?